back to the Dissociative Table podcast. I'm Alex Furchess. This is the second part of a 2-hour conversation I had with Dr. Sandra Paulsen, EMDR dissociation issues guru, and one of my personal heroes. In this episode, she speaks about the E in her N.E.S.T model of complex trauma treatment, which stands for embodied. And that if you aren't working with somatic interventions, you're not really working with complex trauma at all. She begins speaking about neurofeedback and neurofeedback type interventions, some of which aren't so expensive and therefore inaccessible to practitioners who don't have that $30K for lens equipment and training. She speaks about how somatic interventions are integral to working with traumatized clients, and new research involving low-dose naltrexone that may overcome some objections to this work in the medical community. She speaks about the similarities of somatic dissociation to the phenomena seen in split brain studies and the role of hemispheric specialization. One interesting aspect that we get into is the possibilities for team treatment with bodywork and massage therapists, where Sandra points out some of the big dangers of this type of work and perhaps how to mitigate against those. I think the most important part of this episode is a conversation about misconceptions surrounding so-called repressed memories and how perhaps this term was flawed in the first place and very misleading. She ends with speaking about how she got into the complex trauma field through EMDR and its dissociation magnet capability, where she was no longer able to ignore the complexities of chronic childhood traumatization. Before we move on, I wanted to ask about the other part of the N, the devices. So neurofeedback is the one that most people think of. Right. And I did speak to a couple people about that because I thought, well, that's cool. Maybe I can do that. The setting that I work in, we have a place that could have a lab and all of that. So let's check that out. Well, okay, starts at $25,000. And then I would need to get a tech. And then I would have to change the whole structure of how I do sessions. Good luck getting insurance, much less in my area. It's largely Medicaid. You know, I work in like an impoverished rural setting. And it's like what you're speaking about, the devices, and of course, we don't want to name companies, or you didn't want to. I really don't care. The devices you were speaking about are much more affordable. And that's something clinicians listening who don't have $25,000 may be interested in hearing a little bit more about.
Well, and the reason that I tend to not mention brand names is if you're trying to get CE credits for things, but you're not trying to get CE credits here, so it doesn't matter. And in fact, the only neurofeedback system that I can speak about is the one that I've used, and that is LENS, which stands for low emission neurofeedback system, I think. I don't know, by Len Oaks. And you can find it at oakslabs.com. Or it's on my website, paulsenpsychology.com. And I think there's a products or store page, and any products that I mention are the links there are there to the manufacturers. But it was my colleague and co-author Ulrich Lanius that got me interested in LENS. And I stopped doing it with COVID, and I haven't picked it up again because it turns out I'm busy doing other things. But there's no doubt in my mind that it potentiated changes. And it's just that it's very detail oriented. And I'm much more an idea person than a detail oriented person. So I wasn't prepared to invest that time and energy to learn about it. But people who are, I mean, it's a great way to go. And so I was sitting here with this. It's probably, I think it cost me $13,000 for the whole system. And I had it sitting here, and my husband used it, and I used it because he got trained at the same time with myself. And we just think it's great. We use it for ourselves, even though I'm not using it right now with clients. I don't object to using it with clients. I think it's great. I'd recommend it. for people that have the appetite to learn details.
Mm-hmm. Yeah, and it's also, you're investing in a very technical training as well.
Right.
The other things you mentioned Bluetooth tappers.
Right. I'll take them off their charging cable. These are touch points. They were invented by our colleague Amy Sarin, and she wanted something for ADHD or autistic kids to use for self-soothing, and they're going, I don't know if you can hear them, but they're buzzing alternately. And I mean, the buzzing is not helpful. The sound isn't helpful. It's the buzzing, it's tactile stimulation without cords. And she invented them for the public to use. So they stand alone without the EMDR protocol, and they're soothing, unless if the intensity is too great. And I have those little like runner's zipper wristlets. Where are they? They're not here. Oh, here's one. These things that have the little pocket in it, and you can put that inside, and my patients wear them sometimes. See, and so there's that, and that really keeps people in the optimal mid-range of arousal, as does the alpha stim. I only work, I'm trying to turn these off. I only work intensively, and that is, I only work with people these days 3 days in a row most of the time, and so often people are flying in from far away, and I want to, if they come in and they're anxious because they have only met me briefly online, then they might have high anxiety, and I'll put the alpha stim on them. Do I have it here? Yeah, I have one here. I didn't know we were doing show and tell. Fortunately, most everything's within reach. This is mine. I travel with one because this one has both the one that you put on your ears for alpha waves in the brain, which is a relaxed, alert state. But it also has these sticky pads. I don't know if you can see those.
Oh, yes. Right. Okay. That reminds me of something I've seen that, it's for something entirely different. Yeah.
But these, I travel with these because if I twist my back or my ankle, I can manage pain with them. So you can get the model, the AID model is just for the alpha waves, and the M model has the embodied pain attachments for it. So I'm just more expensive.
And that's something people can find linked to on your website as well?
Yeah, on that same page. It's either store or products, So these are all things that work directly on the brain's emotional systems.
And we're moving toward the E here, but before we move to the E, the embodied of N.E.S.T, one thing that I just thought of when you were saying that is, let's see, so it was a Denise Galinas training with Professor Vanderhart, where she showed a video of working with a client. You never know what to say. OSDD, DDNOS. I think DDNOS sounds cooler, but that's what she used. But she actually was working with the client, holding the tappers, the standard EMDR tappers, just running slowly for the entire session. And this is something, perhaps if somebody isn't doing EMDR, perhaps they're using a pure ego state therapy model, or maybe something even different, they could still use this, but not necessarily in an EMDR way because of what you just said.
Right. Yeah, I just think we need to be clear when we're doing EMDR and when we're doing something else. And using continuous bilateral stim may be beneficial, but it's not EMDR.
Right. Yeah. Okay. So we've covered the N. If you don't mind, let's move toward the E, which I don't know. I'm excited about all of this stuff to talk about it, but this is like has become a special interest of mine recently. Somatic dissociation, or the somatic aspects And that if you don't work with that, you're not working with complex trauma. Like you're just not. Like your client is sitting in front of you. They're not a ghost. So you had mentioned, of course, somatic dissociation, but also somatic therapy. Now, I know that you have a training in somatic experiencing.
But
And
I was trained in somatic experiencing. Yeah.
And so that's surely part of what you mean by somatic therapy.
Right.
But what else is that? Is that just resourcing, or is that central to working with dissociative parts?
So I took one year of somatic experiencing, and then my second year was somatic transformation, and it was the same person that taught both years, Sharon Stanley, who lives here on Bainbridge Island by coincidence. And then she and I shared an office for some years, but she had taught with Peter Levine his third year training, so the advanced training of somatic experiencing for 10 years. And then she went out on her own and taught somatic transformation, which emphasized somatic empathy. But well, I forgot where I was going. Oh, so the idea is, with somatic therapy, is that one slows the person down and has them attend to their body and track in a moment to moment way. And I never got excited about using it alone, except as preparation for those people that can't go right away to EMDR. Somatic therapy trains them in that moment to moment mindful tracking stance. And Gendlin is the one attributed with tracking, but from decades ago, or half a century or more by now. But yeah, people who are somatically dissociative may not be structurally dissociative, but they often learned in the first couple of years of life that they weren't supposed to have needs and feelings. Either nobody's supposed to, or only mom and or dad get to have needs and feelings, or whatever lesson they took away, however it came to pass, they had to clip their dashboard wires and not occupy their body. And so you can't process trauma if they can't tolerate both positive and negative affect and soma, because nothing can resolve. So somatic therapy can help increase people's tolerance of positive and negative affect and soma. And there's another way to get there that I prefer. Because I work with only in the intensive format, as part of my intake process, I ask some basic questions, ask people what they're noticing in their body, so that I'm assessing whether they can tolerate positive and negative affect and soma, whether they can say, oh yeah, I'm feeling heavy in my chest or tears in my eyes, or if they can't do it, if they go like, what are you talking about? Then I know that they're not going to get the full value of their therapy time in dollars, and they're spending thousands of dollars to spend 3 days with me. So if it's like pulling hen's teeth, it's miserable for both of us. I mean, my comfort doesn't matter, but I want results for them. I mean, it doesn't matter in the sense of their therapy. It doesn't matter if it's hard, but I'd much rather get great results for them. So what I do now, and I can't really embark in with these intensive clients with somatic therapy, I could refer them to somebody else. But what I do instead is I have them go on low dose naltrexone, which is no greater than 4.5 milligrams, not the much higher doses used for alcohol and drug addiction. 25, 50, 100 milligrams is used for alcohol and drug addicts, but 4.5 milligrams or less is low dose naltrexone. And there's this magical effect that many people who are alexithymic, somatically dissociative, which is another way to say alexithymic, except different end of the elephant kind of. And a subset of autistics will start being able to discern emotions and body sensations. And it's not like there's trumpets or fanfare. It's just that when a therapist anywhere says to them, "What are you noticing in your body right now?" they have an answer for the first time. They go, "Oh, yeah, there is a little something." And then it takes being on the stuff for months or a year before they've learned everything there is to learn and can stop it. So the way I describe it to them when they say, "How long do I need to be on it?" I say, well, if somebody had clipped the dashboard gauges in your car and somehow you've been driving your car without the benefit of dashboard gauges, and then suddenly they were hooked back up, or more accurately, if somebody found the little dimmer knob and started turning up the light so that your gauges are illuminated, it still might take you a while to learn how to read each gauge. And so that's a very close metaphor for it takes them a while to learn what it means if they feel their heart pounding, or if they feel heaviness in the chest, or if they feel moistening in the eyes. If they're alexithymic or somatically dissociated, they have to learn what that means. And the autistic as well.
Yeah, it in a roundabout way reminds me of studies on split brain people. And that it's not like the client who cannot feel his left side. And oh yeah, it just so happens that when he doesn't sleep on his right side, he becomes very, very anxious. You know, it's sort of like, it's not like he doesn't have neurons and I forget what the ones where the input actually comes in from the skin. It's not like he doesn't have nerve endings in his left side. It's just one side of the brain is not talking to the other.
Right.
And so that seems to be the same sort of concept. I find that split brain concept is very accessible to clients and seems to destigmatize the idea of, we're not talking about anything weird here. We're talking about an emotional brain injury. This is not, maybe there is a spiritual component to the meaning of this, but we're not talking about magic tricks and repressed memories and so on. We're talking about information that it has become necessary to keep mom on the pedestal to not matter, I suppose, is one way of saying it with your cartoon.
Yeah, so, and a lot of people learn to camp out in the left hemisphere, which is language and logic, and they're the ones that come off as intellectualizers or otherwise somatically dissociated or even autistic. And so the naltrexone or somatic therapy begins to open that door. I see where the corpus callosum should be. I see it in the cartoon I'm looking for. I can't find it now.
Right.
But I've got a cartoon that shows a guy sitting at a little lonely table with one light bulb and a gray left hemisphere. And then there's a door, which would be the corpus callosum. And on the other side of the door is emotions and relationships and color and unprocessed trauma.
More to come in the second half of this conversation. Check out Dr. Paulsen's books, endorsed equipment, and more at paulsenpsychology.com. If you're enjoying this conversation and you're a clinician treating complex trauma or a student learning how, email dissociativetable@gmail.com to join the discussion on the Clinicians Only discussion board. I forget, there's one, it's a heart medication. Using a low dose can help people reduce a phobia of parts and make that work easier, so I'm told by trusted colleagues. But whatever that is, it's, yeah, you can do that in Oregon. But where I live in, Eastern North Carolina, psychiatrists are not going to prescribe, much less MDs, are not going to prescribe these things because they don't believe that dissociative disorders exist.
Well, there's a literature, the National Institute of, both the UK and the United States has, the federal government's got a review of low-dose naltrexone available, a review of studies. And just parenthetically, it was Jaak Panksepp that was either the first or one of the first to mention low-dose naltrexone for well-being and for autism. Isn't that interesting? That was in like 79 or something.
Yeah, so yeah, that's the other reason for this program is it's like I wish that when I was out of graduate school, somebody had handed me Looking Through the Eyes of Trauma and Dissociation, because I wouldn't have wasted so much of my professional career.
This one?
Yes, that one, the one that I make all of my certification consultees buy. Like,
oh, thank you.
You can't do certification with me if you don't buy that, because you're not going to get any. I did have a question about that for the S in N.E.S.T, but I'll wait. I want to ask, but I'll wait. I was wondering, if on that note, you ever work with licensed massage and bodywork therapists who are trauma trained or trauma informed. I know that can get into some different territory, but what makes me think of that is there was this guy in town who he was a little bit out there, and he's not in town anymore because he got poached by like a big money resort in Florida. But I was speaking to him because I wanted to collaborate with him, because I thought, okay, I'm interested. And he spoke about working with inflammation, working with the lymphatic system. And of course, oh geez, this goes into my recent interest in schizophrenia possibly being an autoimmune disease, and the inflammation in schizophrenia and the inflammation involved, of course, in dissociative trauma, right, or even small t trauma, creating these odd symptoms of apparent hallucinations and things like that. That's a different story. But he said when working with inflammation, he would find some little knot on somebody, and I don't know, it's more complex than this, but he would mash on it in his LMBT way, and boom, out would spurt a piece of unremembered childhood. I'm very careful not to say repressed memory. It's I think that it's not so much the well has been poisoned as that perhaps that term was flawed from the beginning. Nonetheless,
I think of it as encysted, ENCYSTED, energy, encysted energy. It's sort of stuck somewhere.
Yeah, exactly. It's sort of like the split brain concept. If it's not repressed, it's on the other side of the brain. There's perfect access to it in certain states. In fact, once the client steps in my office, he'll be like, well, I realize I totally remember that, except for when I was in your office. In fact, I told my wife about it. I wonder why she didn't say anything, this sort of thing. But anyway, this guy was saying that sort of memory would just pop out when he mashed on a certain side. And that seems somewhat possibly destabilizing to realize. Shout out to my SD folks, to realize all at once, right? So I don't know if you've worked with LMBTs.
I don't know what that acronym means. I mean,
licensed massage and bodywork therapist.
I have.
Okay, so that's question number one. What's your work with that been like?
Well, I worked with one person who was well known to me because I had done. This is really interesting. He was a former baseball player who was also a Reiki practitioner and massage therapist, and he was really good at perceiving energy holdings. And I'd worked with him personally, and then I'd referred people and to him to work independently, but also we had a few sessions where we were both myself and he were treating the person at the same time. And the that worked well because A, he was very gifted, and B, we communicated really well, and C, he had no hesitation to let me be in charge of the treatment team. And I know that the late Maggie Phillips, in her book, Finding the Energy to Heal, which was about a number of energy therapies, including EMDR and TFT or something, and other things. She talked about collaborating with body workers and said that the clinician, the mental health professional, needs to be in charge of the treatment team. And it's true, because it's possible that you can overdose. If the body worker thinks that they're a trauma expert and they're going to process and release trauma, and the client is also in therapy and they're going to process and release trauma, there's a question of who's managing the dosage. Mm-hmm. Maybe it's not a problem, but maybe it is. Because it would be like having a number of doctors prescribing different antibiotics at the same time. Having said that, I guess I'd recommend Maggie's book, because she goes into it at some length about how to collaborate with body workers. I think what I have found, it's interesting. I haven't tried it lately, but I wouldn't hesitate if things were really stuck. But because I'm working only in the intensive format, there isn't time to say, let me refer you. Mm-hmm. But if I were working in a conventional format, I'd have no objection to doing that, as long as that therapist knew that if I said, I think he needs to just have buff and puff this week, nothing deep. Because he had a huge abreaction and we're trying to synthesize and consolidate gains. That you have to have that clear overseeing of where the person's at.
Yeah. Like you also stand the chance of, regression into an even greater phobia, I suppose, if there's it seems like for the grief process, progressive realization, like titration of the dosage of realization through the client's own curiosity, as opposed to just mashing out the traumatic memory or something like that, is critical to getting the whole client, as opposed to just part of the memory, which may be inaccurate.
I've had a lot of training, but there are times that I'm, it takes everything I've got. And when I see people hanging out shingles that really, they're not mental health professionals, so they're only working with trauma from a body perspective, I don't know how yes, it's a different end of the elephant, but it certainly seems to me that there's some risks there.
Mm-hmm. Yeah. Perhaps for an inpatient model, right, where they, like Ad de Jong, who I mentioned earlier. I don't think I even said his name, but anyway, there's your Sidetrack guy. You're like one of he's such an iconoclast. He's just an automatic hero for me. So I hope to have him on this program, actually, but he's really busy. But yeah, they are preparing for an abreaction that they are intentionally creating, right? Like they're doing prolonged exposure type stuff to prepare the client to tolerate an abreaction that they are inducing, such that they can rapidly reprocess the material by overworking the working memory. But it seems to me that a danger with getting really good with doing that in a private practice setting is something that happened to one of my consultees, which is a massively destabilized client. Now, thankfully, this didn't happen while I was the consultant, but he was exploring body sensations with the whole body, as opposed to just stopping when the client was curious about something. And a particular memory was spontaneously realized, to the great disturbance of the client. And it seems like that was not helpful to the grief process.
Right. That's why, well, in 1991, I was trained in EMDR, and I had a anxiety disorder specialty at the time, because I was associated with the anxiety clinic at Queen's Hospital in Honolulu. And I immediately started using EMDR and started uncovering undiagnosed dissociative disorders, which I was not trained to identify in my CBT program at the University of Hawaii. I mean, no, at that in 91, nobody hardly was trained to recognize it. But I started uncovering undiagnosed DID folks in my own practice. And fortunately, within a month, I was able to get to, at that time, it was called International Society for the Study of Dissociation, or it was ISS-MPD, multiple personality disorder.
I
And I
had to
heard
change
George
that
Fraser.
one.
Yeah, it's been through like 4 name changes.
Yeah.
And I heard George Fraser, who coined the term dissociative table. I heard him talking about using that procedure. And so I've always, since that first month, I've always used ego state work in conjunction with EMDR. But the point I was going to make was EMDR is a dissociation finder. So lots of people bust open dissociative clients in a very unfortunate way. Now, Francine's contributions were at least twofold. One is the discovery of the effect of eye movements, and the second one, and that's Francine Shapiro, for those of you who are not EMDR people, but her second contribution was that she developed this protocol so that you don't just bust things open, but you prepare people and you tidy up and you follow up, and it's got a whole protocol for safe process. And anybody who's using bust them open methods better darn well have something equivalent to prepare the client and follow up with the client, or the person can easily, based on their trauma history, make real, even dangerous inferences about the meaning of something.
Right.
Especially because when trauma, like if somebody has a flashback of the fiery car crash at age 33, and they have a flashback of the moment before the collision with the tractor trailer rig in front of them, their heart might pound, but it doesn't take them too long to realize, oh, I'm in my therapist's office, and that's a flashback. But when the trauma is in implicit memory, because it's in the first few years of life, then what they get hit with when the memory gets opened up is the intensity of the emotions and body sensations, but without a picture typically, and without narrative. So then they're just flooded with, for example, if the memory included rage and shame and despair and hopelessness and terror at age 2, but there's no picture that goes with it, and they're hit with all that, and then they leave the therapist's office because there's no process to guide it, or leave the body worker's office because there's no process to guide it, then they're left to make inferences about what's going on. And they very often, left to their own devices, will say to themselves, I'm ashamed again. I must have failed again. I feel like despair again. It must be hopeless after all. I'm feeling enraged again. I've been violated in present time, and they don't realize it's a flashback. And that's the hazard of lack of preparation, lack of a process that supports throughout, and lack of follow-up. So
thanks so much for listening. I hope you do look into some of the resources that Sandra either mentioned or wrote. It certainly changed just about everything that I do. In the next episode, she'll get into the S of N.E.S.T, the self, introducing and demystifying ego state therapy as a way of working with complex trauma. We speak about the accessibility of internal family systems, but also the severe limitations that come with that accessibility, and how ego state therapy may bridge the gap between more descriptive yet less accessible psychodynamic theory and that accessibility of that package deal of IFS. Sandra focuses her discussion of the power of ego state therapy around the concept of ego cathexis, or adding ego energy to parts of self to validate and allow the client to more fully realize traumatic memories. I present a devil's advocate objection that often cited by opponents of this way of working, that therapists give clients parts by adding ego energy in this way. And Sandra has a nuanced and excellent answer to that. I hope that you have enjoyed this episode and will tune in for the next one. Until then, goodbye. And as usual, our music is provided by the band Crack Machine in support of worldwide increased access to effective trauma treatment.